Hey everyone, my name's Karmena and I'm one of the students on the Laparoscopic and Robotic Surgery module. And today I'm just be giving a brief presentation on laparoscopic female sterilisation. So a quick overview of what we're going to talk about today. I'll start by giving some background about female sterilisation, and then we'll just talk through the methods of laparoscopic sterilisation and what it aims to achieve, along with a step-by-step of the procedure. We'll also talk about hysteroscopic sterilisation, and at the end we'll touch on some post-operative complications that patients might experience after laparoscopic sterilisation. So in terms of background, laparoscopic sterilisation is a procedure which aims to provide permanent contraception by blocking or removing the fallopian tubes. This is an elective procedure for patients who decide that they don't want any more children or they don't want children full stop. And it's really important that patients are fully informed and counselled before making this decision. And they should be consented properly and spoken through the whole spectrum of alternative contraceptive options that are available to them, such as long-acting contraceptives like the Mirena coil, the IUD, the pill, and the implant. It's just really important to ensure that they understand the benefits and the risks of sterilisation and the fact that it is meant to be permanent. Due to this, it's quite difficult to reverse. It can be done, but it's not often very successful, and reversal of sterilisation is not routinely available on the NHS. So I've just got a brief summary of how tubal sterilisation works, and also a diagram of the anatomy of female reproductive organs. So essentially the aim is to cause a blockage or prevent the passage of the egg through the fallopian tube. So the egg is released from the ovary, and usually it travels down the fallopian tube to the uterus, and sperm will go through the vagina, through the cervix, and through the uterus and meet the egg in the fallopian tube. But with tubal sterilisation, it prevents the egg being able to move along the fallopian tube, because there'll either be a blockage or a cut, so the egg won't be able to reach the sperm, therefore fertilization cannot occur. And fallopian tubes can be blocked by many different methods, including placing a clip across the fallopian tube, banding a section of the fallopian tube, or electrocautery to cut and burn a section. Alternatively, you can do a salpingectomy, which is the removal of the fallopian tube and or ovary. And then the anatomy of the fallopian tube, you have the fimbriae here, which are the finger-like projections, which are closest to the ovary. So they receive the egg from the ovary, then the infundibulum, then the section called the ampulla, which is where fertilization most commonly happens, and then the isthmus, which is the narrowest section of the tube. And this is the target for tubal sterilisation. So this is the section that surgeons will want to block, because it's the narrowest and therefore easiest and most effective for this procedure. So some methods of laparoscopic sterilisation, there are several. I've just got this diagram up here to illustrate some of them. The one that I've most commonly seen is the use of Filshie clips. So essentially, clips are placed perpendicular across the fallopian tube, the entire width of the fallopian tube, and the clips are placed which essentially what happens is the clips crush the fallopian tube. They exert pressure on the fallopian tube, so this causes avascularization. So there's no more blood supply to this section of the fallopian tube, and then this causes fibrosis to occur, which will form a blockage, so the egg can't pass through the fallopian tube. Similar to this, there's banding. So what they do here is they use a suction style instrument that it's loaded with a band, and they essentially draw up a section of the fallopian tube. They suck it up through the suction machine. The band is then rolled on, and it forms this little loop, which is banded. So this again causes avascularization of this section, which will cause fibrosis. So again, there'll be a blockage in the tube and the egg can't pass through. Another option is using electrocautery to cut and burn a section of the fallopian tube. Usually they would use bipolar for this, as it minimises the risk of heat injury to any of the surrounding organs like the bladder or the bowel. And then another option is to tie and cut the fallopian tube. This tends to be done as an open procedure, so often after a C-section. It's been pre-planned, and they'll just cut a section of the fallopian tube and then tie either end with a suture. So steps of the procedure, I'm just going to talk through laparoscopic sterilisation using Filshie clips. So firstly, the patient will be consented, prepared, put under general anaesthetic. A catheter will be inserted to drain the urine from the bladder, which sort of compresses the bladder and moves it out the way, so there's less risk of injury to the bladder. Then, as with all other laparoscopic procedures, the ports will be inserted. They'll insufflate the abdomen, fill it with carbon dioxide, insert the camera and the instruments needed, and sometimes they use a uterine manipulator, which basically moves the uterus to create the right tension and the right view for the surgeon. Once the instruments and camera are in, the next step is to identify the fallopian tube, and it's important to follow it to its fimbriae to make sure that you have the right structure and make sure that it's near the ovary, attached to the ovary, rather than clipping the round ligament or something. But they can look quite similar in laparoscopic view. Once you're satisfied that you found the fallopian tube, you identify the mid-isthmic segment of the tube, as that's where you'd want to be placing the clip, as it's thin and therefore easy and effective to block. Then outside of the abdomen, there you'd load the Filshie clip applicator with an open clip and then insert this device into the abdomen. To do that, you'd have to close the clip, not the full way, but a little bit to get it through the port, and then once it's back in the body, you can open it up again. Then you place the clip perpendicular to the area of the fallopian tube that you want to block off. Make sure that it's completely across the whole width of the tube, because if it's not, then there's a risk that this will fail and that there will still be part of the tube that isn't blocked off, and so the egg can pass through. And then once you're satisfied with the positioning, you slowly compress the handle and squeeze on the handle for 10 to 20 seconds until you can see blanching of the fallopian tube. So the tissue will go from pink to a whitish colour. Then after 10 to 20 seconds, you can release the handle, relax on the handle to release the applicator from the clip. And then repeat that entire process on the other side. And this tends to be a day case procedure, so most often after this procedure, patients can go home the same day, provided there are no complications or any other issues. So hysteroscopic sterilisation, I just wanted to touch on briefly. This is a minimally invasive alternative for sterilisation, and it works a bit differently. So they use a hysteroscope, which is a camera that goes through the vagina and the cervix and then the uterus. And they use this to insert tiny coils called microinserts into each of the fallopian tubes. These microinserts then cause an inflammatory reaction, causing scar tissue to form around these coils, which blocks off the fallopian tube. So again, the egg cannot travel from the ovary to the uterus. And so some benefits of hysteroscopic sterilisation are that the patient doesn't need to be under general anaesthetic, they can be awake, and it can be performed in a clinic rather than having to go to theatre. It's quite a quick procedure and it's less invasive because you're not making any additional cuts into the abdomen or anything. In terms of limitations, there are a few. So it can take a few months for the tubes to be fully blocked off. So you need to keep taking contraception for 3 months after the procedure, at which point you'd have a scan to see whether the tubes have been blocked. If they have, then great, and if not, then you need to keep going with the contraception. The alternative forms of contraception. There have also been increased reports of pelvic pain after the procedure, and it's associated with a higher risk of gynecological complications than laparoscopic sterilisation. So for these reasons, this was quite popular at one time, but it seems to have sort of died out a bit now, and it doesn't seem to be being performed as often. In terms of post-operative complications, as with any surgery, there's a risk of bleeding, infection and pain after the procedure, and also damage to other surrounding structures such as the bowel and the bladder and the ovary. There's also a risk that this procedure fails, so there'll be a contraceptive failure, and there is a risk that patients can still get pregnant after this procedure. And if they do get pregnant, there's an increased risk of that pregnancy being an ectopic pregnancy, because obviously it's harder for the egg to move through the fallopian tube. There's a risk that the fetus will start to develop in the fallopian tube rather than in the uterus. And then an interesting one to touch on as well was regret. That's why it's so important that patients are fully informed and counselled before making this decision, because it is a permanent form of contraception. Studies have shown that there's an increased risk of regret if the patient is young when they make this decision, for example, being under 30, if they've just had a big life change or a big medical issue, such as an abortion, if they're unaware of the other contraceptive options available to them, or if they're under pressure by their partner or their family to make this decision. These can all lead to an increased risk of regret. So thank you very much for listening to my presentation. If you have any questions, let me know. Thank you.